Well, hi everyone, and welcome back to my YouTube channel. Thank you very much for stopping by. Today I have an extremely interesting interview with Ryan Smith from TruDiagnostic. He is going over my personal age report. So TruDiagnostic do age testing. So they use a whole range of different clocks that tell us how well you're aging. And when I first got this report, I had a heart attack. Now, the first number on there, which is the extrinsic age, came up not so great, and I was like, wow, why? And then I thought about it. I've lived a life of an extreme athlete, so just put this in perspective. A friend of mine said that you've lived the equivalent of a sort of Rolling Stones rock star lifestyle, doing extreme sport, and obviously some of that is written in my DNA and in my methylation clock. However, Ryan has gone through this entire report for me and shown where I'm absolutely nailing it, which I'm really, really excited about, and it's the most important pieces of this report. He also talks about some of the limitations and some of the exciting developments that are coming in their OMICs report, which they're about to launch in a few weeks, which will really start to give us information about not only what your, a number for your biological versus your chronological age is, but also what systems are doing better than others. Like, is your heart aging at a faster rate? Are you the stem cell divisions? How often are you dividing in your stem cells and the effect that that's having? They can also look at some of the lifestyle things that you've done, like have you drunk too much in the past? Have you been exposed to smoke? Have you got a high risk of diabetes or obesity? Some of these things are already in their reports. Ryan does say that there's some limitations with those things, but the new reports that's coming out in about 3 weeks' time, which will have the omics updates in it. And the beautiful thing with this company is you do the test once and they'll keep updating the report. Sometimes there's a tiny little fee if they have to pay for an algorithm or something, but it's really going to be able to keep up with you. And what's coming also is their fit report. I've forgotten the exact name of it. This will be, they are able to see things like your grip strength and your balance test and your coordination and all of these things from methylation, not doing the test, not doing the grip strength and all of that stuff, but actually from your blood sample that you send in for this test. So absolutely amazing what this company is doing. I do think that this, while at the moment people haven't mostly not got their head around what this is, and it's just a number that gives you a chronological versus a biological age, but this is actually so much more. They're looking at everything from telomere length to genetic risks to omic reports to the fit side of the reports to the DunedinPACE study. So there's lots of nuance to this conversation. It's an area where I'm realizing I'm going to have to start to do more study in order to implement this in my clinic and to be able to use this. And I really encourage other doctors and clinicians that are out there, healthcare professionals, to start to educate yourself on this, because this is going to give you predictors of how well people are doing way before anything, even things like cardiovascular disease actually pop up or atherosclerosis pop up on scans. You'll be able to see the changes, and this is where the power in this lies. Even looking at your immune age, red cell distribution width, and your things like your neutrophil to lymphocyte ratios, all of these things are going to be taken into consideration. There's CD4 to CD8 ratios. There's just already they're doing a heck of a lot, and there's more to come. And as it gets validated, there'll be, so in other words, you have to keep up in this space. It is an evolving space. It's not a perfect science. The first generation clocks have got some limitations, as you'll see in my report. What he said, that's neither here nor there really, but that DunedinPACE report, mine came back at 0.69, which is apparently absolutely exceptional, which means I'm rating only at the aging at the rate of 0.69 of a year for every year that I'm on the planet. And that is an exponential decrease in the risk that I have for many of the diseases, and really shows me that a lot of the stuff that I'm doing is clawing back some of the damage that I perhaps did as a young person. And also some of the stuff that, that I'm implementing now is really having a massive impact. One of the interesting ones was alcohol. You can do a self-reporting, and then it looks at some of the damage, and I was concerned that mine was higher than the average when I don't drink a lot. However, there was a period after my father died when I was drinking a glass of wine every day. I certainly hadn't lost the plot, but I was not coping, and that shows up in my DNA, so to speak. So what also came out of that conversation is probably because I know my own genetic risk factors for the glutathione family of genes, and I have very, very poor genes in that respect, and I have very poor inflammatory genes. So for someone like me, I have to be extremely careful if I'm going to expose myself to any sort of toxins, and I've known that, but really that was written in my DNA today. So I hope you enjoy. This is bearing my soul, bearing my DNA from the inside out. Was quite difficult for me to do, but I wanted to share this with you because I think it's going to be powerful for you going forward to understand this space, and to it's really motivated me to double down on some of the good things I'm doing and to maybe change some of the things that I'm not doing so well. So I hope you enjoy this interview with the brilliant and amazing Ryan Smith. He's absolutely fantastic and just a genius brain. So I hope you enjoy it. We'll see you over on the other side. Perfect.
Okay. Sounds great. Well, great. No, I'm happy to go ahead and get into it. But I know that one question is going to be coming first, which is, why I'm not as worried about some of these metrics as you might think. So if you don't mind, I'd love to just go ahead and get into a little bit of background on exactly why that's the case. So we don't bury the lead and get you worried for nothing. Is that okay?
That sounds very good, because I had a panic attack when I first saw it.
No need to worry. So, to talk about why we trust different algorithms and outputs more than different others, I just want to go into a little bit of the history here. And I think we talked about this briefly when we spoke on the podcast, but, these clocks originally started in 2013, and first they weren't even meant to be health predictors, right? They were meant to just to be chronological age predictors. So again, trying to date people if they left their DNA at a crime scene to see how old they were, or to use in refugees to see if they were adults or minors and therefore eligible for asylum, right? So then they started to be used in these really large cohorts. And when they did, they found an interesting pattern, which is that those people who were older than their chronological age were at negative risk of outcomes, and those people who were younger than their chronological age were protected, right? But these all were still on clocks that were trained to predict someone's chronological age. And really, we would consider these first generation clocks a little outdated. And so these intrinsic and extrinsic clocks that we put are still these first generation clocks. And I want to go over some of the problems with them, because generally the better that you make these clocks, the closer they get to just telling you your birth date, right? Which is not something we want to do, because you don't need an expensive test to tell you that. Most people don't, I should say. But with that being said, these clocks right around 2018 started to become a little bit more sophisticated. And they got more sophisticated by, instead of training it to predict chronological age, they trained it to pick up the biological effect, right? So we're not looking at things that are just correlated to chronological age. We're really trying to pick up the biology of aging. And so the ways that these changed was that they started to be trained to biomarkers, phenotypic biomarkers of aging. So things like Morgan Levine's PhenoAge, which looked at 9 blood-based biomarkers, like serum albumin or red cell distribution width, for instance, or in case of GRrmAge, looking to predict time until death as the major output, or telomere length, for instance. And so these clocks got better. And the way that we know they got better is that they were more predictive of negative outcomes. So the people who had the same acceleration on these algorithms were at much higher risk of negative outcomes. And those people who were younger, at the same as the first clocks, were even more significantly protected from those outcomes. So we know that this was more predictive because it was capturing more of the complete biology of aging. Does that make sense?
Yeah, absolutely. Yep.
Perfect. And so lastly was the one we talked about, a lot, the DunedinPACE, which also captured biological phenotypes, but instead of Morgan Levine's 9 biomarkers, it used 21 biomarkers. But the most important thing is it did it over time. So it actually measured biomarker change from the time that these people were born all the way until the time they were, now 51 years in our most recent follow-up. And so This DunedinPACE is the only third generation because it spans across time. And so just to show you a little bit of this, I want to show you, for instance, that Horvath clock, like our intrinsic clock. One standard deviation increase in that represents a 2% increased risk of mortality, whereas one standard deviation for the DunedinPACE represents a 64% increased risk of mortality. So again, as we're trying to figure out which one's more important, we're going to go with the one that predicts 64%, not the one that predicts 2%, right?
Gotcha.
Does that make sense? And so going back to your results, if we're looking at them, you might initially have been concerned because you're seeing this, right around the 6-year age gap. And that is certainly a little bit higher in our cohort, but our cohort is also, I should mention, super competitive, right? Some of the people who are doing all the amazing things that you are as well. And then we also see this with the extrinsic, where even though you're lower, you're probably still a little bit above average. And so at one point in time, this was the only tool that we had. But now if we look at your DunedinPACE, we see something that is extraordinary and makes a lot more sense, quite frankly, right? Based on all the things that you're doing. You can look at your DunedinPACE and you are definitively like on the outliers of this in terms of age group, right? This is an excellent score. And this is the one that is by far the most predictive. So again, going back to the, that PowerPoint that we were sort of talking about, you can see it even compared to all these other clocks. It beats all of these other clocks in terms of, relationship to classical biomarkers. It's the most precise. Here it beats every other clock in terms of precision. That means that it's really accurate. And if we tested your sample multiple times, it would be the most consistent. And then in addition to that, this is the one that's the most important. And this was written by Jamie Justice, a researcher at Wake Forest, who was basically saying, are these clocks ready for clinical trial use? And the answer was no when she wrote it in 2020, because of this last point that had not been satisfied, which is, are these interventions responsive to changes that we already know beneficially affect biology? And thankfully, the DunedinPACE showed that this was correct. In a caloric restriction study, we saw that this went down, which is exactly what we would expect, because caloric restriction is a pretty well-validated intervention for aging across a lot of mammals. The problem, though, was that these first generation clocks, or ones that used age, actually went up with this intervention, which we know is not correct, right? And so the only one to go down significantly was that DunedinPACE. And so not only is this the most predictive and precise algorithm, but it also changes to interventions we know beneficially affect aging. And so for this reason, that's why we're prioritizing the DunedinPACE above all others. Do the others, does the initial one still have correlations to all those negative outcomes? Yes, but not as high of correlations or high as predictions as the DunedinPACE. And so we're always going to prioritize this marker over these other classical markers.
Can I ask you, just interrupt you there for a second if I can? So when, like I've lived Greg actually McPherson said to me, I'm not surprised even at your intrinsic age, you've lived the life of a rock star, basically, as far as being an athlete, right? So I've smashed the crap out of my body for 30 years before I got into the anti-aging longevity world. Is that what's being reflected, even though these aren't, these are first generation clocks? Is that, like showing that, hey, up until this point, or say up until 5 years ago, you did smash the shit out of yourself, and we can see that, and now you're clawing your way back because the DunedinPACE study is sort of showing, whatever I'm doing is working now.
Certainly. So this is these are all the factors which are weighted some of these early algorithms. And so particularly, we're looking at these blue and red. These are the most similar. And so you can see all the different associations. And you're absolutely right. Physical activity is a weird one because, you see these really small parts right here. The effect sizes for the extrinsic and intrinsic here are, for one, going in the wrong direction in the case of the extrinsic. In the case of the intrinsic, are very small. And that's exactly right. You're exactly right, because these had, what we saw with these was sort of a biphasic response, where some activity was great, but too much activity was actually negative, which is limiting some of these associations. And so certainly, that could be one of the reasons why. But again, what we're seeing in these chronological train clocks are correlations to age, not necessarily, correlations to biological phenotypes. And so there could be a whole host of reasons why your intrinsic age is a little bit more accelerated. But whenever we see a Dunedin-PACE of 0.69, that would alleviate any concerns of a fast aging. I mean, you're setting an outlier here, which is amazing. And so this is definitely the one that we would care about. And it's also way more highly linked to a lot of different outcomes, not just death and disease, but all of these different things that you would see here. So balance, gait speed, so how you move about the world, how you think in the world in terms of, your perceptual reasoning, working memory, IQ even, and then even how you look as well with, that graphic we always like to show. These are real images of people who are 45 years of age. All of them are the same 45 years of age, but these are what the slowest aging members of the cohort look like versus the fastest aging members of the cohort. So again, the Dunedin-PACE is also not only the most predictive of all disease, but it's also the most predictive of all these quality of life factors we also associate with aging. And so again, this is why we prioritize it so much more. And just to let you know, in the next 3 weeks, this intrinsic and extrinsic are actually going to come off our platform. We'll be replacing it with a new report that we've spent the last 3 years working on, which you will absolutely love. And I'm sure that you're going to score much, much better on that.
Yay. Being a very competitive person too, this is really good. But like looking at that extrinsic, so that is looking at the immune system, and from my teachers I know that the immune system can tell us a heck of a lot about how well we are doing, and I have noticed that I've got some issues in that department. So is that does have some correlation? I mean, I'm minus 5-6 years, but is that still going to come off because it's not exact? I mean, your red cell distribution width and your neutrophils versus your lymphocyte ratio, is that what you're looking at there?
I'm looking at it, yeah. So generally what we would want, I would say for most people, their extrinsic tends to be around 8 years lower on average than their intrinsic. And so for you, you're 12 years, which is better. But what we're seeing is that you're still a little bit above average in our cohort in terms of that age rate. But again, that's not necessarily bad. And so again, because our cohort is so competitive, right? Our cohort is the who's who
top 1% of the world who do this stuff.
Yeah, exactly. They're doing everything they can. They tend to be affluent, they're able to spend a lot of money on their own healthcare. But one of the things we really look here is that CD4 to CD8 T cell ratio, because as we get older, we become more immunosenescent, and sometimes that can drop the CD4 to CD8 T cell ratio. But yours is exactly where we would want it to be. It's between 1 and 4.
Oh, good.
And so that's perfect. I think that your ratios look really good. And some of our new reporting, we'll expand this even further to tell you a whole host of immune cell subset outputs. So just to show you, this is what a new immune report will look like, which will include even more cell types and then also even more ratios. They can tell you each a little bit more. And so that again will be happening in just a few weeks in terms of updates.
Okay, so and people who have the old reports, are they going to get updates, or that you have to test again to get the new report, so to speak?
Yeah, no, we'll update all of the data. For some of them, we have to pay, particularly for one algorithm, our new OMICm algorithm, which will look like this. We do have to pay a license fee to Harvard for our co-development. So I think it's going to be an additional $15, which will all go to Harvard, but everything else will be updated for free. So all of your immune ages will be updated for free to this. We'll update your CRP inflammatory reports and cognition, and then we'll also update all of your summary reports and everything that we can as well. So we don't charge unless we have to. We're paying another.
That's amazing.
But yeah, for your results, again, this is certainly not bad, and this Dunedin-PACE is excellent. I know we talked briefly about the Rejuvenation Olympics, but if you were to probably take 2 more tests over the course of 6 months and you had something consistent here, you'd probably be in the top 5 of people with their Dunedin-PACEs.
Well, let's do that. I want to win the Olympics, right? Come on.
This is our Rejuvenation Olympics website, which shows, so you see some notable people on here like Peter Diamandis and Ben Grenfield and Steve Aoki is on here as well. So I'd love to have you on.
Hell yeah.
The requirements are 3 tests over at least 6 months.
Okay.
But I'll send you that website in case you want to register at the very least. But this Dunedin-PACE I'm jealous of. This is awesome. And if there's one metric I'd want to score well here, it's this one right here.
Oh, amazing. That's amazing. So all of the hard work that I have been doing over the last 8 years or so, since I've been in this world, and since I stopped being a crazy athlete, smashing the shit out of myself, it has been paying off, obviously.
Yeah, and to be honest with you, we see a lot of the same pattern in a lot of our physicians, right? Because they've let's just say an ER medicine physician who just works 14-hour shifts
crazy
a week, tears their body up, residency, all the different things that these physicians do. They might sometimes have poor ages, but then their rates of aging, now that they're in this integrative cash-based space, are much, much better, right? And so this is not an abnormal pattern, but I would say it's abnormal to see this low of a DunedinPACE. This is a great score here.
Oh, I'm so stoked because I work really hard, right?
You should be stoked. That is a DunedinPACE that is phenomenal.
Wow.
And so it's definitely something to be happy about. The last of our age-related biomarkers, at least for now, we will be adding our fit age, which I imagine you'll score very well at. But we also have telomere length. And again, I just want to talk a little bit about why we don't love telomere length. I don't want to belabor the point, but telomere length, although correlated to aging, is not really predictive of any outcomes in aging. And so we always like to cite this paper, which says that telomere length is extensively validated, but it has low predictive power. And so with that being said, this telomere length has better predictions of many different types of outcomes, but this is the one thing I like to show as well, which is that in the Generation Scotland cohort, they did an analysis of how much these things impact your overall phenotypes. And looking at those first generation clocks, like the intrinsic and extrinsic clocks, compared to these other, markers like telomere length affects 2.8% of the end phenotype. Whereas even biological age, even those first generation clocks represent over 28.5%. So again, as we're comparing which ones are more important, definitively those biological age clocks. And we've got data to suggest that the DunedinPACEs represent over 45 to 48% of those phenotypic outputs. And so again, we don't care about telomere length quite as much as we would with some of those other markers. But with that being said, your telomere length is still, pretty much right on average. And so 7 kilobase per telomere length, puts you right around where we would expect, which is right on that average trend line, probably a little bit higher.
Yeah, and there are things, so, we do still use telomere length as a predictor of, so just for those listening, telomere length are the little chromosomes, the little shoe caps at the end of the chromosome, so to speak, and it's how much you're getting close to the end of that cell life cycle, if you like, isn't it? So
definitely.
it's not as good as what we used to think it was going to be, the telomere length. Although people that are really sick do have short telomeres, don't they? So
and there are a lot of reasons. So one of the things that we oftentimes say here, if you're in the bottom 20%, is you might want to consider like a course of senolytics, because generally if you have low telomere lengths, it means that you probably have more replicative senescence, where your cells have gone into senescence as a result of losing too much telomere length, right? But interestingly enough, we just did a trial with probably the most popular senolytic regimens, dasatinib and quercetin, and it actually significantly shortened telomere length by these. And so we still might recommend fisetin, but we don't recommend the combination of dasatinib and quercetin, which significantly showed telomere attrition. The one thing that's also been correlated in meta-analyses to be better for this measurement is omega-3 fatty acid supplementation. And so we do recommend that, but it's not something that's going to change overnight. It's going to take, some time to change. And one of the other things I'll send to you is a PowerPoint, which is sort of what we call the 8 reliable ways to reduce epigenetic age. So it goes into all the things that you should stop, all the things you might want to consider starting, and then all the things which have validated interventional trials. And so I'll give you this as sort of a cheat sheet, so to speak, of what changes each algorithm. And we also have sort of this I would say provider interventional sheet, which talks about all the studies which have been published with different interventions and how they've affected each of these different markers. So it's another good cheat sheet. Some of the things we always recommend are things like vitamin D, stress reduction, better eating, more plant-based diets, for instance, and DASH and Mediterranean diets as well. So we can go over that toward the end of the call a little bit deeper if you want to, but overall, I think that your aging your aging outcomes are a little bit conflicting, but not too much, because again, we're going to trust this DunedinPACE, and this is incredibly strong. You know, even if you're slightly above 1 here, you'd increase your risk of death over the next 7 years by 56%, and you increase your risk of a chronic disease diagnosis by 54%. So we really want to keep
really reducing my rate massively of having, you know, some horrible disease. Which is, that's just absolutely amazing.
And all those quality of life things too, right? Balance, cognitive decline, grip strength, even facial aging, all of those things are correlated to this marker.
And I know, like, things like grip strength, I'm off the charts, or one leg balance test. You know, I know from just, you know, doing not this test, but other tests that, those are exceptional. So that's great. So
good, and you should, like you said, be very happy about that, because those are great scores. And so, so that's, I would say, really it for our biological age reporting. And I think overall, you have a lot to be excited about here because of that DunedinPACE. But we also have disease-specific reporting too. And this is something we traditionally wouldn't give direct to consumer. We'll only give through our providers. But I would love to go through it with you, at least briefly, if that's okay.
Yes, please, because I didn't really understand this.
Yeah, and this can be a little bit more complicated. And I'll send you this PowerPoint as well, which is our interpretation guide of how to go through some of these disease-specific reports. But the first thing we like to do is this mitotic clock. And so this mitotic clock is a measure of the number of stem cell divisions that you have per year. And this is sort of an incidental finding that occurred as a result of one question, which is that, you know, we have certain tissues in our body that have cancer at higher rates than others. So for instance, our thyroid gets cancer at a 1% rate, whereas our pelvic bone gets cancer at a 0.003% rate. And so people were sort of asking the question, why do certain tissue types have cancer at different rates? And the first thing they ask is it genetic? And genetics only explained right around 10% of the variance. Then they said maybe it's environmental exposures, and that only explained 15% of the variance. But what they started to see is that the total number of stem cell divisions in a particular tissue actually correlated very linearly with the lifetime risk of cancer in that tissue. Right. And so the idea here is what we call this bad luck hypothesis, which is that the more your stem cells replicate, the more likely they are to create a DNA error in transcribing that DNA. And then the more likely that error is to create cancer. Right. So that's sort of the thesis and hypothesis here. It's been proved out pretty well. Here you can see this is sort of the epitoc, or the scores that we have. And then also on the bottom, you see the different normal tissue versus intermediate cancer versus, you know, pretty bad dysplasia. And you can see that the rates of the stem cell replication tend to increase. Same here with different other types of tissues. And so this is, again, pretty well proven. What we're doing, though, is we're not measuring tissue, we're measuring blood. And so what we really want to see here is that your score is really lower, right? We want you to not be in that top 5 percentile, essentially. And what we're seeing here for you is that you're around the 72nd percentile, which is certainly not bad, especially for your age group. We're, again, sort of right around, you know, barely over that average trend line, which is good, right? So we'd probably see no increased risk of cancer with this particular marker. The other thing that we would do is type 2 diabetes risk. And what we see here is that you're not at increased risk for type 2 diabetes. Sometimes this can be falsely elevated with people taking a statin, which is something I always just like to say incidentally, because everyone always likes to debate statins. But one of the interesting things about statins is that they do increase your risk of type 2 diabetes. And the way that they do that is by this one receptor, actually, which makes insulin secretion less likely to happen. And so we know that statins tend to increase risk of type 2 diabetes because they increase methylation at this ABCG1. And so it's a great proof of concept to show that, hey, this is the mechanism of action of these epigenetic effects actually impact your disease risk. And that's why statins increase risk of type 2 diabetes.
Wow.
So I think that's just an interesting aside, but you have no risk here, which is great. This is what we would want to see. If you do see a patient with an increased risk, we would recommend doing some type of action to try and treat that. We also have an
this one was
report here.
This one was interesting.
It's not a good report. We're taking it off our platform. We developed this in a Spanish patient population where 30% of people read an increased risk. Then we went to a US patient population, and right around 92 or 93% of people read increased risk. So everyone I see here reads an increased risk. You're actually, you have one no increased risk, which is surprising. I usually don't even see that. And so I would just ignore this entirely. It doesn't work, I would say, outside of a Spanish patient population.
Oh, great. Because I was like, I'm like really lean, you know.
Definitely.
Am I doing a lot of things right, and therefore I'm lean? And if I let go, I'd be like really obese really fast. Or
Definitely. And that's one of the problems with these algorithms. Sometimes we can't tell you cause or effect, right? We can't tell you, you might say you're high risk, but that doesn't mean you have the phenotype, right? But this is one report that everyone loves and tends to be highly accurate. And so in this report, we're actually able to tell you how likely are you to respond with weight loss to caloric restriction. And this is not always something you want to see as full response, right? As people get older, for instance, and we recommend caloric restriction as an intervention, right? But we don't want older people to become frail or have sarcopenia as a result of decreasing their their caloric intake. And so so here though, you are probably one of the 8 to 9% of people that are non-responders, meaning that you're going to have to work a little bit harder to lose weight than most other people would be.
Wow.
And so it means that you might have to balance a multitude of interventions, right? Aerobic, anaerobic activity, making sure your hormones are optimized and making sure you're insulin sensitive more so than other people. So you might have to work just a little bit harder with the same amount of caloric restriction that other people would.
Wow, that's interesting because, when I was younger, as a young girl, and I didn't know anything about diet and everything, I really did struggle with my weight. And now when most people are struggling with their weight, right, menopause and hormonal changes, I'm not struggling with my weight because I do 100 things to not struggle with my weight. I'm like constantly, things like berberine and metformin and rapamycin and, peptides and exercise and everything, in saunas and a whole raft of things. But from a genetic tendency, I would have that tendency to put on weight at this if I didn't.
Yeah, definitely. You're just going to have to work a little bit harder, and we have seen this change in people too. So we're not sure quite what makes it change just yet, but we do know that this tends to be pretty predictive.
Wow. Okay, so I'm going to have to work to keep it where it's at.
Just a little bit more than other people. And this is just with caloric restriction. So it might mean that, your levels of activity might help you lose weight more so than others, but this only is relationship to caloric restriction as an output. And so just something to mention. We also have smoking and disease risk reports. It looks like that you have a relatively high drinking rate, which might be a little bit higher than we would normally see. But it also,
just a comment on that one. So, 3 years ago, I lost my dad. And for a couple of months after that, or a few months after that, I was having like 1 glass of wine a day to cope with life, right? I was
certainly
grieving really bad. Is that written in the report here? Like, is that what I'm seeing here?
So
damage that I did.
We don't know with drinking. In the case of smoking, there, which you don't have, I would say you have no increased risk for. So it's very unlikely that you've smoked for any significant period of your life.
No, I never smoked, but my mother smoked during pregnancy, and my parents smoked my entire childhood.
Yeah, this is on the lower end, which I was going to suggest that you might have been exposed to some secondhand smoke. But unfortunately, at this low side that we're looking at, it never changes if you've been a smoker. So we can see if you've been a smoker or a former smoker, or you've been a never smoker. And what we see here is that you're in that never area, but you're sort of toward the lower end of that never area, which might suggest that you've had some exposure, but you've never particularly been a heavy smoker. In the case of our alcohol consumption score, we're not really sure of the timelines. So we created this score by basically looking in our cohort and asking how much they drink, right? So we basically created a methylation risk percentile from 0 to 100. And in each of these categories, you can see the average and then the relative sort of error bars here. And what we ask in the registration is how much do you drink, right? And so you reported that you drink once per week or on special occasions, but your methylation risk score looks a little bit more like someone who regularly would drink.
Which is, because I don't now. I did for a few months there after Dad, died. Is that to do also with things like your GST? Like my GST family of genes are an absolute disaster. So I have no glutathione. My GST T1, M1, and P1 are just completely disastrous, and my MTHFR and methylation genes are also poor. and the SOD2 and the GPX gene are also poor. So would that have a correlation? Like, I just don't handle alcohol well if I do have a drink?
So we don't know, to be honest with you. And we definitely need to do more of that analysis. But we tend to, one of the things we would like to see in a perfect report like this is no overlap of these individual, squares, right? Because these become ambiguous, but we're not really sure what all puts into that. And so we're creating some better alcohol risk predictors. Right now, we can even predict how many pack per years you've smoked. We can even predict how much you use marijuana or MDMA. But we don't put those on the reports, obviously. The drinking one needs a little bit resolution, but unfortunately, people's behaviors on drinking are usually not always very consistent. And so it becomes hard. Some people might high binge drink, but they might only do it once a day, versus some people might drink small amounts, but they do it every day. And so some of these behaviors from alcohol perspective tend to be a little bit harder even than other behaviors. But we published a trial on this, and I'll just pull this up so you can see it, where we looked at the impact of smoking, alcohol, and marijuana use, and then its relationship to different diseases, which is also interesting because we were able to, for instance, connect things like marijuana use to anxiety related pathways, for instance. And so some really cool things here. And that was only in 2,000 patients, one of our first studies that we performed, 3,000 patients in our cohort. And so even with really low volumes, we can find some really interesting things. And so, but again, it looks like that there might be, I think all of those reasons you said might be reason that yours is accelerated here.
Yeah. So in other words, with my body type and my genetics, I probably just can't get away with anything. Don't do it.
And generally, people who have what we call alcohol use disorders, which is just heavy drinking, more than generally 6 or 7 drinks per week, are on average 2.2 years accelerated compared to those who are not. And so, really, I would say that we haven't found any amount of drinking which is positively correlated to better aging.
No, I agree. I think it's just there is no, and this whole resveratrol red wine thing. It just takes a resveratrol.
Yeah, definitely. I love another controversial one, but I think with all that to be said, this is a pretty good report, right? No increased disease risk. You might have to work a little bit harder to lose weight, but your rate of aging is phenomenal. And some of the other reports that we'll come out with, just to sort of show you briefly, that will be on your newest reports, is we will give you an inflammation report, and this tends to be much more highly related than your classical blood-based biomarkers of CRP to neurological outcomes. And so I won't go over this too much, but I will just show you a couple images which show you how much better it is than classical CRP. And so, for instance, if you look in a cohort against aging, DNA methylation CRP shows a trend with age, but regular CRP doesn't. And that's because CRP is too fluctuating. It can change up to 1,000-fold within an hour. This DNA methylation CRP is a little bit more consistent. And so we can see trends we don't normally see. This is the same with cognitive function. Here we see DNA methylation CRP is highly correlated to cognitive function, where regular CRP is not. And again, we can see this even on brain MRIs with the brain. Here on the bottom left, you can see these are the phenotypes of the brain. And you can see in the white is regular CRP, and the effect size in the red is DNA methylation CRP. And you can see that we are much, much more associated to brain outcomes than regular CRP. And so for all those reasons, our predictors of CRP have a little bit more benefit than regular CRP. And we also include IL-6 in that comparison as well, because it's also highly related to those brain outcomes. And so you'll get that on your next probably update within probably 2 or 3 weeks.
That's great.
Yeah, the other report that we'll do is that fitness age, or what we call the OMIC fit age. The fit age acceleration was originally developed at UCLA, but we changed it with some algorithms and some better methylation risk scores. But we'd be able to tell you what your aging rate is as a result of your fitness. And again, this is not nearly as good as that OMIC age, but what it's helpful for is keeping you honest on the level of fitness activities or fitness behaviors that you're doing, because we'll be able to tell you your grip strength, your VO2 max, your gait speed, and your FEV1, and tell you where you sit on that percentile. This is obviously separated by sex, as grip strength and FEV1 in particular are very different with sex.
What is FEV1? I don't know that one.
Yeah, so it's the amount of forced expiratory volume you can have in your lungs. So if you breathe in and then just breathe out as much as you can, that's essentially what FEV1 is, how much you're breathing out, that forced expiratory volume. And it's another predictor of fitness and health as we age, much like VO2 max, but less metabolically inclined, so to speak. Oftentimes has to do with how well your lungs are fibrosing as well.
Yep.
And so, but again, these are just sort of additional fitness biomarkers. Just like we want to keep you honest with your smoking and drinking behaviors, we also want to keep you honest and make sure you're exercising, right? And this is a way you can strive to continually improve on there.
So how are you going to measure that? So that's going to be, you know, like, do we have to self-report that to you guys? What the, you know, and get this tested somewhere? Or, oh,
yeah,
wow,
not at all.
this
So
comes out of the...
what we've done is actually we've measured this and methylation in a group of people. And then we basically told methylation to predict these outcomes. And so just with methylation, we're able to predict it. Same with IL-6 and CRP. That's the exact same way we did that as well, as we measured CRP in, you know, thousands of individuals, and then create an algorithm to predict that, which works fairly well. And that's actually where, you know, I would say we're going just generally with a ton of things. And I'll show you, so we can actually...
blowing.
Yeah, it's super cool. So just to let you, so in our newest OMICage report, for instance, whenever we tell you, we're going to be able to tell you what's increasing or decreasing your age. So we'll be able to tell you what your HbA1c is, your hemoglobin, your creatinine, all through methylation as the sole biomarker. But even that, we can tell you about, you know, your insulin-like growth factor 2, or, you know, different metabolites like uridine or carotene-diol, or all these different things just from methylation alone. And so we're really excited about where methylation can go, but we think it eventually can predict 60 or 70% of all the blood-based testing you would traditionally do, just with this one test.
Wow. That's amazing, because then we'll be able to track people without, you know, and we'll be able to do this ourselves and get really in-depth things that you usually, when you go to the doctor, you can't get.
Exactly.
You know, you're just not going to get half of this sort of stuff. So,
and
or you have to do
advanced.
we
think the cost will also be driven down eventually, and we think that you can do it with a simple blood stot instead of a lot of blood, meaning you don't, you know, it'll make it more accessible to people who can't go to the physician as well, have to worry about, you know, refrigeration of samples, or, you know, some of those other things. And so we certainly think it'll be an amazing public health tool as it continues to grow and expand.
Oh, I'm excited for this, Brian. It's just absolutely amazing.
Yeah, this preprint will be coming out even just early next week. So I'll share it with you, and all the cool things we can do here. And again, with our new OMICage, these are all the things that are associated with better or worse, you know, aging, where, you know, smoking, drug use, calendar age, BMI are all things that will increase your aging rate. Whereas, you know, antioxidants, sexual activity, omega-3 fatty acids, and physical activity are all shown with better aging. So nothing here that's too surprising, but it's good, again, that we're seeing consistency with what we already know.
Yeah.
Mm-hmm.
It's just absolutely mind-blowing. And in prediction of, you know, like when you've got different organs with different aging rates, like this is the you know, one of the things I was talking with Greg McPherson about this week was, you know, like like you said, your heart may be aging faster than your liver or your kidney or whatever. Is that going to be a part of what you're going to do?
Yeah, I don't see my screen now, but so these are, in the case of our OMICage, these are all these methylation risk scores that we've attributed to certain systems. And Yale just recently published a great paper on systems aging. And what we're going to do is actually combine the two, combine all of our independent methylation risk scores of these individual metabolites, proteins, and clinical variables with some of that organ age specific rationale or makeup. And so we're really excited about the ability to offer that in the future, but we certainly will be able to score each of your systems even already.
Oh, wow. And so you'll be able to say, and will you put this in the reports? Like, would this be updated in reports that, hey, I'll know that my, you know, heart's not doing too well?
Not immediately, but we will certainly in the future. We want to make sure it's publicly validated before we add it to our report. And so once we publish on it and then look at different organ systems, we'll be able to make those ideas. And eventually, this is what we imagine happening, is that if we want to create a risk score, for instance, for diabetes risk, we can start to do that with methylation, much like we would for age. But instead of trying to predict time until death as an outcome, we'll predict diabetes diagnosis, right? And in that, we'll include our predictors of HbA1c, or we'll predict our, you know, all of these, I would say, you know, endocrine system related things things like, hormone levels or IGF-1 or fasting glucose, right? All of those will then help us predict this ultimate outcome. So we can tell even very early clinically that these things are on its way. Another good example of this is recently they showed an article that said that your DNA methylation aging can predict subclinical atherosclerosis. But before you develop, heart attack, you would actually see your omic age increase. And that's
so you'll be able to do it even before a scan would pick it up.
Correct. Exactly. Yeah. Then that's sort of the technical term of subclinical. So we know that methylation is highly responsive to some of these changes, and we just want to be able to read those patterns so that we can interpret them and tell, you and your physician before any other method. And I think that's a really interesting part.
And will these reports eventually have then lifestyle, full lifestyle recommendations of what you should be thinking about taking or doing that you do in conjunction with your practitioner?
So we don't give a lot of recommendations on the report, and the reason being is that we never know everything that's going on with the patient, right? And so we never want to conflict with what their physician is telling them, but we try and do a ton of education on what we know to change each of these markers. And so we try and educate, but not recommend. And I think that and until we know a lot more and these things have been more thoroughly validated, we want to be just extra cautious. So so traditionally we can talk about all the things, for instance, that increase or decrease your HbA1c or your fasting glucose, and how that is probably going to decrease your aging rate. But we're not necessarily going to say, hey, your HbA1c is in the top 90th percentile, as we might see on this, and then say, as a result, we recommend berberine or dihydroberberine or metformin or SGLT2 inhibitors or whatever it might be. We're not going to make those recommendations. We think that should happen with a clinician, but we might be able to tell you your HbA1c is what's increasing your aging rate the most, and we might want to change that.
Wow. And so for any clinicians sitting, out there in the audience, how do they get themselves trained up in this, and how, and moving forward, what sort of educational things will they have so that they can, like, I, want to have this in my practice? How do I do that and be able to interpret these tests as they continue to grow?
And that's the thing, they keep always increasing. And so we do frequent education. And so anyone at TruDiagnostic is available to review those directly with a clinician to make sure that we can educate exactly how we would use it. We have a couple other really good resources, like I showed you our report interpretation guides, and which tell you sort of what we would recommend, everything from, establishing why longevity and aging is important, to what is DNA methylation, to how should I interpret the DunedinPACE, for instance. So we have a lot of resources and give a lot of education, and we're going to be starting to do a lot more education on our OMICm starting on August 10th. Awesome. And so we're going to have a lot of different education things available.
Perfect. So just head on over to TruDiagnostic.com, and that's all available on there.
Definitely. We also like to educate consumers. So we have a YouTube channel which has a lot of this information as well.
Yeah, fantastic. This is amazing. Yeah.
Perfect.
Because it's just getting it out there, and people understanding the implications of this. And oh, by the way, I love the book behind you.
I was about to say, I didn't know if you noticed it.
Awesome. Appreciate it.
Yeah, definitely.
It's a fast moving place, and it's quite a paradigm shift for clinicians and patients to get their head around why do this test and what it's going to bring, and where the science is at currently, where not to place too much stock, where there's still work to be done on behalf of you guys, and where this is potentially going. That's the exciting thing. So yeah, like, this has just been absolutely amazing, Ryan. I can't wait to share this.
And I'll continue to update you as those new reports come out in case anything is surprising. But just judging from my estimation, I would imagine that once we have that OMICm algorithm, you're going to see your age decrease pretty substantially versus what it was in the other algorithms, because we're really measuring that biological signal, just like we would with the DunedinPACE. And I think you'll see it be a lot more consistent.
Yeah, this is gold. So if I want to do that Olympics thing, I'll have to head on over to that website. So you'll send me that as well.
I will. I'll send you that as well as a bunch of these PowerPoints, so you can always go through it yourself. And if you have any other questions, just let me know.
Absolutely fabulous, Ryan. Shall we stop the recording there? And
yeah. Perfect. Yeah, I'll stop it right now.
Oh,
and